Hello there, and welcome to Yodo. I'm Dr. Sarah Bone, and today I'm going to provide some information that was prepared by Dr. Minh Le. Dr. Le is completing her internal medicine residency in Orlando, Florida. She worked with me for a few weeks on our palliative and hospice medicine service at the hospital. Her areas of interest include palliative medicine and oncology. She provided education to her colleagues and agreed to allow me to share this information with you here on the channel. Anorexia-Cachexia Syndrome is not only limited to patients with cancer, but can also be associated with advanced stage of other illnesses, such as chronic kidney disease, COPD or chronic obstructive pulmonary disease, AIDS complex, advanced stage of rheumatoid arthritis, cirrhosis, and certainly heart failure, particularly congestive heart failure. But many illnesses can also have some components of anorexia-cachexia syndrome associated with them. This medical issue is a complex one with metabolic changes that describes the involuntary weight loss that can be extreme in some patients, particularly within a person that has a malignancy. There are many chemical mediators occurring. Some lead to intracellular oxidative changes resulting in the breakdown of proteins inside of the patient's muscles. Other chemicals adversely affecting the patient's appetite are also present, and other hormones that result in an increase in resting energy expenditure. The result is unavoidable weight loss. As research is ongoing, more concerns have also been found. All of these are occurring independent of each other, each one of these factors, but these factors also affect one another. So you're already beginning to think that this is a complicated problem? Yeah, you should, because it really is. For some patients, loss of appetite may explain part of the weight loss, but for many others, calorie intake may not be significantly different. They can have loss of muscle and fat tissue coupled with poor appetite while feeling less hunger and the sense that they are full early into the meal. There are symptoms of fatigue and weakness that are the result of this metabolic derangement, and they're brought on by chemicals that are released into the person's body by the cancer. This is a very worrisome problem, as there are significant negative impacts onto the patient and their success to maintain their health as well as their function. It can impair their ability to have a satisfactory and quality of life that they find pleasing. When this syndrome occurs, it's a poor prognostic sign as well. This syndrome has a very worrisome outcome. This syndrome can directly contribute to the development of respiratory failure or heart failure and add to the disease burden that the patient is already experiencing. This increases the risks up to the patient's health overall. So a cancer patient can develop lung issues or heart issues because of this process. And if the patient, with or without malignancy, already has a heart or a lung issue, this will further accelerate that problem. So it gets really complicated very quickly. Patients will have numerous symptoms. Both physical and emotional distress often occur. Patients and their loved ones can also have a lot of existential suffering and spiritual concerns when this syndrome occurs. I'm going to review some of these here and some of these causes as well as what we're trying to do to treat this problem. There are often significant physical as well as emotional symptoms for these patients. Thus, the workup is involved and complicated. Poor appetite is reported by some patients, and others simply say they can no longer eat a full meal. Fatigue with low energy levels are common complaints. Needing more sleep or reporting that their sleep that they do get is not refreshing is also very common. Weakness and declining strength with significant limitation of their ability to ambulate, sometimes feeling so weak that they feel like their muscles are shaking, is a common report of most patients with this syndrome. Weight loss is significant. The body mass index is used to monitor the patient's weight, but as muscle mass is declining, some patients might be retaining fluid, and the weight might not seem to change on the scale, but it's certainly noticeable that the muscle bulk of their arms and legs is declining. A person with a body mass index of less than 20 becomes particularly worrisome. Studies show that as much as 80% of patients with advanced cancer can have this problem. It is particularly prevalent in patients with GI and lung malignancies, but can affect nearly any patient with cancer. It can be shockingly rapid for patients that are frail or elderly. We need to make sure that we're not missing something, so a thorough evaluation needs to be done. There are considerations such as problems directly related to the tumor location or possibly from medications that need to be considered. So we have to look for a possible treatable cause. This is an extensive list, and I'm just going to include a few broad ideas here. Mouth irritation or dental concerns, pain with swallowing are possible causes for weight loss that is unrelated to this syndrome. We need to rule out GI symptoms, possibly heartburn, upset stomach, nausea, vomiting, constipation, diarrhea, or an intestinal infection. We need to rule out endocrine issues being the cause, such as a thyroid problem, diabetes, abnormal calcium levels inside of the person's body. Other organ systems also declining included but not limited to kidney problems, liver issues, heart dysfunction, and lung disease can certainly result in weight loss. Particularly infection, because that's a stress to the body, so we need to look for infection and signs and symptoms that might lead us to that. Of course, might be cough or upset stomach or skin infection, but looking for a possible treatable infection. Social issues, including poor understanding of their nutritional needs, social isolation, needing assistance with food preparation, and even with eating. Certainly financial or transportation issues could limit a patient's access to good food as well, and those need to be evaluated for. There are mental health concerns, including depression or anxiety, among many other mental health concerns, and those diagnoses need to be evaluated for as well. That's a lengthy list of things that we're looking for when we're looking for a treatable cause of this syndrome. Physicians can use the Functional Assessment of Anorexia-Cachexia Therapy questionnaire because this can help with identification. This is a patient response questionnaire that asks questions across several domains. The first section asks about the patient's impression of their physical well-being. Next, there are several questions about social and family support. The next 6 questions ask the patient about their emotional well-being. Then there are questions for the patients regarding their functional level. And the last section has 12 questions that cover a wide range of patient concerns. This information helps guide the clinician and provides insight into the patient's capabilities, physical changes, and their growing limitations. Once the workup evaluation has been completed and other causes have been ruled out or addressed, this leads the clinician to the diagnosis of Anorexia-Cachexia Syndrome. At this time, it is a diagnosis of exclusion. So let's talk a little bit more about what this is. Anorexia is the loss of appetite because of a marked reduction in the desire to eat, and it's often associated with psychological causes. But for cancer patients, typically these take a back seat to the metabolic and inflammatory changes that are contributing to the reduced calorie intake. Cachexia is a complex medical syndrome. This is characterized by ongoing weight loss. For some patients, the weight loss is limited to muscle, and for others, it is a loss of muscle as well as fat tissue. These changes are not able to be reversed by typical nutritional support. It is commonly seen in patients with advanced cancer as well as other end-stage chronic conditions. As we said, kidney disease, lung disease, or heart disease. As anorexia-cachexia is partially caused by inflammation and metabolic changes that are associated with the malignancy, it is not easily treated. Unfortunately, for many patients, it is not reversible. Because of the profound effect on the patient and their functional status, as well as their biological reserve being depleted, it can render a patient unable to tolerate their cancer treatment. Many cancer therapies carry an inherent dangerous side effect list. When this syndrome occurs, it is one of the more worrisome issues for cancer patients because it represents that worrisome prognostic finding, as it might render the patient unable to tolerate further cancer treatments. Being told that you are not a candidate for more chemotherapy is truly frightening and is contrary to what you see on the commercials on the TV that imply that you can always take something for your cancer. That's not always true. Patients have a complete mental block on how this can happen, that they're not able to take more chemotherapy. For cancer patients, the combination of poor appetite and weight loss occurs frequently, Anorexia and cachexia diminishes the patient's quality of life and can limit the patient's ability to receive treatments, as often those aggressive chemotherapy agents have their own side effects that are quite worrisome. Many oncologists have concerns that if the patient has an aggressive malignancy, adding more burden by administering a toxic treatment may increase the likelihood of making that bad situation even worse. This is a complex medical issue, this syndrome is, and it carries with it significant psychological and even spiritual implications in addition to those physical symptoms that we talked about. There are inflammatory chemicals called cytokines, as well as hormonal changes and metabolic derangements that are occurring. There are tumor-produced chemicals from some cancers that can contribute to this issue. Some counterproductive processes occur chemically inside of the patient that increase the destruction of protein and decrease the ability of the body to make proteins. There is a resting energy expenditure that's elevated significantly, and the patient can burn calories higher than their normal rate even when they're at rest. It can be a very difficult problem for them to maintain the weight that they have and seemingly impossible for them to gain weight. If the patient does respond to medications to gain weight, these appetite stimulants that we're going to talk about in a few minutes, it often does not result in gain of muscle mass but fat tissue instead, leaving the patients feeling lethargic and with an increased weight that they struggle to carry around. It can be frustrating for patients as well as their loved ones, leaving them with a mixture of anxiety and fear for the patient while having concerns that their loved one is somehow not trying, or worse yet, accusing the patient of giving up and not fighting. Please don't use hurtful words or make these types of accusations if your loved one is struggling with Anorexia-Cachexia Syndrome. I assure you that your loved one is fighting bravely each and every day. This complex process can be broken down into various systems being adversely affected. There is a damaging effect that causes the body's ability to manage and properly use glucose effectively to become impaired. This insulin resistance can lead to further reliance on the body's own muscle and fat stores for energy. The body begins to be in a catabolic process, a destructive process of accessing its own protein sources to run the daily metabolic needs. The body uses its own muscle and fat tissue as a preferred source of needed calories rather than from the oral intake of foods and fluids. Unique to cancer patients, they may have tumor-derived chemical factors that can directly promote muscle and fat breakdown in addition to these other processes that are occurring. Compounding this issue, several cancer treatments can contribute to the loss of appetite as a common side effect. Taste perversion, nausea with or without vomiting, bowel issues are also very common occurrences with many cancer treatments. Next, there may be growth hormone resistance. This will result in muscle synthesis limitations as well as further contribute to the loss of muscle mass. The patient becomes thinner and weaker, furthering their fatigue. Additionally, there are altered levels of appetite-stimulating hormones and altered brain response to the hormones that the patient is producing. Again, adding more to this burden, the body already has multiple competing needs for the calories and the nutrition, contributing to an additional layer to this already complicated problem. Many patients are told by their oncologist that while they are getting thinner and weaker, the tumor is growing larger and stronger. Researchers are looking for and have found some inflammatory markers that can be tested for, but this research has not yet provided answers regarding successful interventions. Treatment success is not close. Sadly, when these processes of poor appetite and increasing catabolic state are coupled, the irreversible progression of weight loss and declining functional status reflects a very poor prognosis for your loved one. During the first stage of this process, the patient can lose up to 5% of their weight as one of the early signs of these metabolic changes. Next, the patient develops cachexia with more than 5% weight loss or a BMI of 20 or less. And sarcopenia may be noted. This is significant loss of muscle mass without loss of fat tissue. The final stage is refractory cachexia. Here the weight loss is severe and the patient is left very weak. There is noted loss of the fat pads of the face, the periorbital fat pads, the buccal fat pads, and temporal wasting. Significant muscle loss volume from the extremities and trunk occur as well. Bony prominences are more apparent. The joints can look more apparent and larger as the tissue around them becomes less. The ribs of the chest and back may be quite visible. The sternum and clavicle can appear larger than normal, and when lying flat, the abdomen can have a very flat or even a sunken appearance. At this point, the patient's clothes are often very loose-fitting. The patient is often quite weak and may be needing help to perform many, if not all, of their own activities of daily living safely. The person might be dizzy or possibly unstable on their feet. Thus, there's an increased risk for fall. Trauma from fall is extremely high in this population and brings with it another layer of increased risk. Patients and families might miss some of this, or they might discount the importance of some of these early subtle changes. They might be thinking that this is just a short phase or possibly a brief or recoverable side effect from one of the treatments, and soon it's going to get better and they'll regain the weight. Often denial is a significant part of patients and families not realizing that this process is a part of something progressive that is more worrisome than it appears on the surface. Some families might not notice it is happening at all and can be completely blindsided when they learn about the presence of this syndrome and its significance. This is a devious and often stealthy process for many patients. Our current management approaches are across several domains: nutritional support with dietary interventions, pharmacological therapy that addresses stimulating the patient's appetite, physical activity, formal if the patient qualifies, and informal if the patient is not a candidate for a rehab program or insurance won't cover one, as well as palliative medicine evaluation and obtaining recommendations from this specialty. Unfortunately, we have no established treatments, processes, or medications that have proven to have a high success rate curing Anorexia-Cachexia Syndrome. Nutritional support is the first step, educating the patient regarding high-calorie and high-protein foods, especially having the patient lean into protein-dense foods and calorie-dense foods that the patient likes and can easily consume. It's advised to liberalize the diet and avoid restrictive diets that might be low in fat or possibly low in salt or otherwise low in taste. Many patients with this syndrome already suffer from taste perversion and have food avoidances because of these tastes, textures, or how it might make their tummy feel. Emphasis on foods that the patient enjoys that go down easily and successfully, as well as foods that the patient feels good after eating. Mealtime should be a happy time, not battle time. It should not result in burden to the patient or the family. Forcing or guilting patients into eating does not provide good results. Patients that are pushed to eat can have abdominal symptoms including pain, nausea, and even vomiting. Vomiting puts the patients at risk for aspiration and developing a pneumonitis. That's a chemical pneumonia from inhaled food or food particles. Even tiny amounts or droplets can be extremely irritating to a person's lungs. Patients should look forward to meals and not dread the approaching time to eat. A tactic that we use in facilities to encourage patients to eat is by providing smaller portions and refilling the plate as the food is consumed. Seeing a full plate of food can be a huge turnoff for some patients. Another commonly used technique takes advantage of the social facilitation of eating. When patients eat together, they tend to eat more willingly. Patients do better when the other people around them are also eating. Patients that are left to eat by themselves or alone in a room to eat by themselves are not as keen to eat as those who are seated at a table with others eating and possibly having conversation. Nutritional efforts alone have been found insufficient, though, due to those metabolic changes that we talked about earlier. For some patients, it seems that even though they are eating more, their weight loss can even accelerate, and sometimes that's true. Enteral and parenteral nutrition might provide some improvement, but many patients are not a candidate for these interventions. For those that do receive this type of support, this intervention is brief. These treatments are only for a short period of time, and they require close follow-up with frequent lab testing. They might even require hospitalization. Needing this level of nutritional support is also a very poor prognostic sign. Medications that can be used to stimulate appetite include olanzapine, which is an atypical antipsychotic medication. It's being used for an off-label reason in these patients. There can be side effects, but this one is often particularly well tolerated. Progesterone analogs, such as one commonly used by patients or requested by patients and families, is called Megace. And it might improve and possibly result in some weight gain. However, this medication carries many worrisome side effects, including blood clots, fluid retention, and it can possibly affect the patient's adrenal hormones, resulting in some other issues. Sadly, the weight gain from this medication, if it's successful, is fatty tissue and not muscle mass. Glucocorticoids or steroids can be used to result in improved stimulation of the appetite, providing some improvement, but they're not able to be tolerated for very long due to their risks and side effects. This drug class can lead to GI upset or even ulcer, and it can contribute to muscle wasting. So this might result in elevated blood sugars as another side effect or frequent urination. This medication class can even suppress the immune system, rendering the patient at a higher risk for several different types of infections. So it's got a pretty significant side effect profile with it as well. Mirtazapine is an antidepressant, and it does have some side effects of increased appetite along with it, as well as improved sleep. This medication has few worrisome side effects, and it is tolerated quite well. It can be used for a longer period of time than some of the others that I just spoke of, but the appetite stimulation is modest at best. Most of these medications do require monitoring and are generally just not able to be tolerated for prolonged periods of time. The most disappointing news about each one of these is they don't result in improvement of the lean body mass. They don't result in the return of muscle tissue. Thus, the modest weight gain is typically adipose or fat tissue. For most patients, gaining weight that is fatty only actually makes them feel worse, and they find themselves maybe less able to ambulate safely because now they can't lug around the excess pounds that they've gained. Sometimes more than one of these medications might be used at a time or in a combination, and it might be tolerated better, but they have to be followed closely, and families and patients need to be prepared that these may not be very successful. There are a lot of side effects to each one of these medications in this group, and they might be tolerated for a short period of time and may show some weight gain, but the payoff is not great for any of them, and many of them cannot be tolerated for very long. There are some new medications that are being studied, but at the time of this video, they've not been yet brought to market. Another intervention is physical activity. This might seem like it's not a very good idea. The patient is already weak and tired, so many people reason that adding an activity might increase the patient's burden. And for many patients, this is unfortunately true because exercise itself is all too taxing. However, for a small percentage of patients, the increase in activity can stimulate other processes in the body to relieve some symptoms and leave them feeling better and possibly improve their appetites. The therapy may be formal rehabilitation or self-directed. For many patients, they may not have the approval for formal therapy as it's not been shown statistically significant for improvement. But improvement of subjective symptoms or objective clinical findings for others is possible. So most patients that have the ability and are motivated with a good supportive home environment, those in-home activities are preferred. Informal activity has many advantages. The patient does not need to leave their own home. If they're too weak, just the trip to the therapy location might zap them, and therefore not much activity is accomplished. Also, when the patient is active at home, they can start and stop at will. They can choose when they want to be active and which activity they want to participate in at what time. They can sleep and eat whenever they like. Schedule flexibility is optimized for patients who participate in a home-directed or self-directed activity program. It's up to them. They can do the activities at their own pace and in the comfort of their own home where there's no copay. There are advantages of formal rehab. When patients are getting therapy in their own home by home health, they'll have a staff member that comes to their house and provides individual attention to them in their home. But there are also disadvantages that are present. It's sort of like having a personal trainer, so that's nice, but that home health therapy has a lot of documentation requirements by the company for the therapist performing the treatment. And that's typically to be done while the therapist is in the patient's home. This can eat away at the time that the therapist actually has available to work with the patient. Another disadvantage is the limitation of other help and services. Because they have home health, there are other services that they might not be receiving because they already have one home health vendor in the home. Home health is only available during the day, Monday through Friday, and they're not available on evenings, weekends, nights, or holidays. Thus, the patients are at risk. They're forced to sacrifice significant help for the sake of having a few hours of in-home physical therapy. Other patients might travel to a center for rehab or even possibly stay overnight in a rehab center for several days or weeks. These rehab centers have equipment, and the therapist may only be working with 5 or 6 people at a time, giving the patient a lot of attention. However, the patient has to have ability to participate to a certain level and must show improvement, or many insurance companies will not continue to cover the service. So it's not always easy to get and keep this type of therapy. Patients that are at a rehab center also report feeling separated from their home and loved ones, and that causes their burden to increase. For some, this problem can be devastating and result in further and even more rapid decline. Many patients have been sick for a long time and they just want to be home around their things and with their family and loved ones. A common complaint from patients about aggressive therapy is the patients feel as if they're paying for the privilege of having a drill sergeant that is unbending and does not really understand how they feel. So there's good and bad with each one of these. Recommended activities do include resistance training, strengthening that will help the patient retain their current muscle mass. Walking can help patients with their balance as well as their endurance. Stationary pedaling or cycling can help with their stamina, as well as for patients that don't have good balance, it's a really safe alternative. Exercise is great in theory, but in practice maybe not so wonderful. Patients might not improve, and for some they might actually regress, become worse, or possibly have an injury or a trauma. Families can become angry when formal therapy is discontinued and patients be left feeling abandoned. It's advised that when patients are motivated and have supportive loved ones, that the therapist educate the patient and family on as many of these activities that they can accomplish on their own at home. Commonly, patients and families have these unrealistic expectations for therapy. Patients and families are often surprised to learn that they're going to have homework even when they're participating in a formal therapy program. They may not understand that the therapist expects them to be working on activities independent of those therapy sessions. The patient's determination and motivation to work on these activities, as well as the support that they get from their loved ones, can certainly make a huge difference in their success. Sadly, though, even with enthusiasm, determination, and hard work, for many patients, the progression of muscle loss occurs unavoidably as disease processes advance for patients with Anorexia-Cachexia Syndrome. This syndrome has impact on function of the patient as well as their quality of life. With increased weakness and fatigue, the patient can become more reliant on their caregivers, and a downward spiral can occur mentally. The less the patient does, the less they can do. Their appetite continues to decline, and the patient's interests and daily joy becomes less. This all results in the patient spending more time in their recliner or in bed. This can affect their emotional health as well as result in frustration, fear, depression, anxiety, and a sense of social isolation. When this occurs, it results in significant psychological stress for the patient and the loved ones. The patient may express those feelings of defeat that can become overwhelmed with these negative emotions. They often report that even with more time in their recliner or bed, they just don't feel like they're getting fitful rest. The patient's loved one see these changes, see the decline in strength and endurance with the weight loss occurring, and panic can set in. Families can inadvertently add pressure to the patient by stressing the importance of eating, taking supplements, and doing activities and exercises. Sometimes the loss of appetite is misinterpreted as a loss of willpower or lack of trying, and patients may hear hurtful words such as "you can't quit" or "don't give up." Both the patient and their loved ones silently know that this represents progression of the malignancy, and it's damaging for both. So open communication and be kind to one another. Because of the anticipated worrisome prognosis for patients with Anorexia-Cachexia Syndrome, the accepted standard of care is for involvement of palliative medicine. Management of symptoms and discussion of what the patient values regarding their quality of life and what they consider suffering is warranted. Patients need psychological and emotional concerns to be addressed. Education of the patient's loved ones is extremely important as well. The patient and those in their inner circle need honest discussions regarding what brings them joy and guidance to alignment of their goals with their prognosis and anticipated trajectory. Addressing the holistic needs of the patient and those that support them can help manage the burden of this syndrome. The patient and their loved ones will have improved outcomes when they're realistic about their body's ability. This is the patient's journey, and all of us should be respectful of the patient's wishes and as supportive as we possibly can. Feelings of helplessness, frustration, anger, or fear are commonly reported. Patients are at odds with the decline of their functional ability and the changes in their physical appearance. Every activity, every mirror, and even every piece of clothing can be a reminder. Many patients voice that they do not look forward to mealtime. Redirecting patients and helping them find ways to preserve their energy for use on meaningful activities, as well as maintaining their independence, can help significantly. Anorexia-Cachexia Syndrome is a real thing. It's a common finding in cancer patients, but it can occur in other disease states. It carries with it a worrisome prognosis, as interventions available provide limited or short-term success. For many, the difficult truth about this process is that it is a likely indicator that the process of dying may already be in the very early stages, and the patient's life expectancy might be short, possibly less than 6 months. How short depends on the patient and the situation, as well as all of the diagnoses that are adding to the patient's burden. If you have concerns, address those with your medical team and don't let them brush you aside. Ask the difficult questions and tell your physician that you are prepared and able to hear bad news if this is the time for those discussions. Studies reflect that patients have expressed their desire to have information and have truth. And many times it's the medical team that has reluctance to provide those blunt information talks about the patient's disease and their prognosis. Welcome that information, even though it's difficult to hear. I found that patients are more brave than we often give them credit for being, and they're more courageous than their loved ones could have ever believed. Patients and families benefit from counseling and mental health support because of the complex emotions and feelings involved with this syndrome. There's often significant psychological distress for patients when they're having unavoidable weight loss. When loved ones understand how to support the patient and to allow for meals to be low stress, it can alleviate everyone's feeling of pressure. Helping patients engage in hobbies and social interactions can assist them with retaining their sense of dignity. A special thanks to Dr. Lee for putting this information together and allowing me to share this here. Cancer anorexia-cachexia is a complex and worrisome issue. This requires a multidisciplinary approach to evaluate and slow the progression. The patient, their loved ones, as well as the medical team must communicate openly about this process and the meaning that this carries for the patient. The patient's quality of life, their thoughts and priorities must be reviewed and discussed. All concerned also need to address the functional status of the patient to try to maintain as best as possible what the patient finds most important and what brings them joy. The goals of care should be tailored to the individual patient preferences. As unpleasant as it is, the clinician and the patient need to understand each other and talk about these difficult truths so that realistic expectations are set. Patients and their loved ones must have information to understand the problem of this syndrome. They're all going to benefit from communicating about the perceptions of quality of life and taking the time to openly discuss their hopes and fears. Patients report less frustration and fear after gathering information and reflecting on these things with their loved ones. Patients' loved ones can benefit from resources like counseling, support group, as well as respite care. Caregiver burnout is a real problem. There is a video on this channel about caregiver support, and I would encourage you to check that out if you haven't. If I've missed something or if you have a question, please drop it in a comment below. Thank you for clicking that subscribe button and sharing this information with others, and I'm grateful for the kindness of each one of you helping others and friends in need. Bye now.